Hello students. So I'm beginning with the series of lectures in pharmacology. Today we will be starting with the session of anti-anginal drugs. Before jumping into the pharmacology of the drugs which are used for treatment of angina pectoris, we will have an understanding about the pathophysiology of the angina, in which we will go on exploring the various targets which are available for the action of the drugs. So when you ask me what is angina is a severe pain in the heart which radiates to the neck, then to the upper jaw, then back, and then to the shoulder. There is a pain in the heart sometimes associated with a feeling of a nauseating feeling or dyspnea or so on. Also, why there is a pain in the heart? Because the heart is the only pump in our body which is pumping the blood to all organs and the tissues, and it has to pump the blood with that much force so that it reaches to the extreme portion of our blood of our body. And now when the heart is doing its pumping function, it needs oxygen, because the energy will be supplied to the heart only through the oxidative phosphorylation or a metabolism, oxidative metabolism, for which it needs oxygen. And who is supplying the oxygen to the heart is a coronary artery. So when a coronary artery blood supply is insufficient to match with the demand of the oxygen by the myocardium of the heart, obviously it will signal alarm as a pain, and that pain is called as angina. So there can be various factors which can trigger this angina pain, like exertion, exercise, stress, and that can further complicate the imbalance between the oxygen demand and the oxygen supply to the heart. The demand is from the myocardium and the supply is from the coronary artery. Typically, angina pain lasts for the period of the 15 seconds, within which you have to treat the patient immediately. If the anginal symptoms last for a period of more than 60 minutes, it may prove to be fatal. But such a discomfort can be abated if you resume back the adequate supply of the oxygen to the myocardium and you restore back the equilibrium between the oxygen supply and oxygen demand in the heart. So let's go more into the detail that when there is an increased oxygen demand by the heart and if there is a decreased supply of the oxygen by the coronary artery, what is exactly happening across the ventricular wall? So here when you look at the ventricular wall of an angina patient, the coronary artery is already having some blockade over here. And this blockade is compromising the flow of the blood through the coronary artery, especially to the deepest portion of the myocardium, that is the subendocardial region. In between the attacks, the end diastolic pressure, that is the pressure of the blood in the lumen of the ventricle, is usually 5 mm of the Hg. But due to the compromised blood supply to the myocardial tissues in angina patient, already the blood supply and oxygen supply to this endocardial region, subendocardial region, is declined. As a result of which it compromises the force with which the ventricle contracts. That will result into the increase in the end diastolic pressure, because if the heart is not contracting forcefully, there won't be a complete emptying of the ventricle and some residual diastolic volume will keep on getting added up into the ventricle, in the ventricle lumen. And that will lead to the increase in the end diastolic pressure. And when this end diastolic pressure increases to 25 mm of the Hg, obviously due to the increase in the volume of the blood and the pressure, the ventricular wall is going to get stretched. And when this ventricular wall gets stretched, you can see there is a subendocardial crunch which is created, which is limiting the extremities of the coronary arteries to reach to this endocardial portion. And therefore, this subendocardial region remains deprived of the supply of the oxygen, and that may create an ischemic condition over here, and that may lead to the pain called as angina. So this is very important for us to understand that why there is a decreased supply of the oxygen to the innermost or the deepest portion of the myocardium, which is required for the proper functioning of the heart. Please remember this point because it will be used in context with action of our drugs. So by knowing this now that there is an imbalance between the oxygen supply and the oxygen demand, the angina can occur in a three types. There can be the overlapping types also, three patterns. One, stable angina. Second, prinzmetal or also is also called as a variant angina. And the third is an unstable angina. Let's go one by one of each type of angina. This angina indicates that there is a mismatch between the myocardial oxygen demand and maybe the myocardial oxygen demand is exceeding the supply. So in stable angina, you can see that already there is a formation of a atherosclerotic plaque which has narrowed down the lumen size of a coronary artery, and therefore it is reducing the coronary blood flow and therefore the oxygen supply to the myocardial regions. It is called as a stable because it is reproducible in the nature, because in those patients who are suffering from stable angina, you will find the pain is occurring when they perform a similar activity with the same intensity. It will faithfully produce the symptom of the angina. And this type of the angina can be therefore relieved by giving certain vasodilators like nitroglycerin, which will increase the lumen size, will increase the coronary blood flow, and will increase the oxygen supply to the myocardium. The second type of the angina is a prinzmetal angina, or it is also called as a variant angina. The difference between a stable and a variant angina is that in the variant angina, you don't see any type of the clot or the atheroma or a plaque in the coronary artery. Instead, there is a constriction, there is a vasoconstriction, there is a vasospasm. And because of the vasospasm in the coronary artery at a particular point, which can be detected from the ECG, as the ECG of such patient will show the elevation of the ST segment. This is a normal ST segment, and this is the elevated ST segment which is observed in patients suffering from the coronary vasospasm and therefore suffering from the prinzmetal or the variant angina. This angina can occur at a rest also. It is very common in the young patient, very common in women, and usually it follows a particular circadian rhythm where such type of the angina attacks takes place early in the morning. The various factors can trigger such type of the angina like consumption of the alcohol, chronic smoking, even hyperventilation. It has been also observed that such type of the anginal pain occurs in the rapid eye movement pattern or a stage of the sleep cycle. This is usually induced by the coronary vasospasm, where you don't see any type of the blockade in the coronary artery, and therefore the treatment which is given from the variant angina and a stable angina will not be same, as the cause behind the decrease in the blood supply to the coronary artery are totally different. In stable angina, it is because of the atherosclerotic plaque. So we need to target the atherosclerotic plaque, which is responsible for narrowing the lumen size of the coronary artery, which is compromising the blood supply and oxygen supply. Whereas when we are treating prinzmetal angina or the variant angina, our target is going to be the vasospasm. That how we can relieve the vasospasm and can dilate the blood vessel and can restore back the coronary blood supply and can fulfill the increased oxygen demand of the heart by restoring back the oxygen supply by the coronary artery. The third type of the angina is an unstable angina where patient is already having an atherosclerotic plaque in its coronary artery. So he is already suffering from the angina and the ischemic conditions into the myocardium, and due to the turbulence of the blood flow, if this atherosclerotic plaque ruptures, then that may cause a damage to the endothelial lining. And obviously when there is a damage to the endothelial lining, it will be repaired by the body by formation of a thrombus, or we call as a clot. So now there is already underlying atherosclerotic plaque. Due to its rupture, now there is a formation of a thrombus, which is an additional obstruction into the lumen of the coronary artery, therefore causing a blockade of the coronary flow and therefore causing a blockade of the oxygen supply to the myocardium. Such type of the angina is very unpredictable, can occur at rest, and not necessary there has to be any exercise or the exertion to the patient. And such type of the angina cannot be only treated with the vasodilators, as we need to understand that there are many factors now involved in obstruction of the blood flow through coronary artery to myocardium. There is a atherosclerotic plaque, there is a thrombus formation, the lumen is completely blocked. So in such situations, you need to give number of drugs and intensive treatment is required to be given to the patient. So now we know that there are majorly three types of the angina. One, that is a stable angina, which is due to the atherosclerotic plaque, can be treated with a nitroglycerin. Then we have the second type of angina, that is a Prince metal angina or variant angina, where there is no atherosclerotic plaque but there is a coronary vasospasm. And the third type of the angina, where there is unstable angina, where there is already atherosclerotic plaque is formed, its rupture is leading to the damage to the endothelial wall, which is further adding up the thrombus formation over the atherosclerotic plaque, and it is the most danger type of the angina. But when we are discussing all these three types of the angina, one thing is very common, that the oxygen supply is not sufficient because of some or the other reason which is restricting the blood flow. It can be a spasm, it can be a plaque, it can be a thrombus, but that is restricting the blood flow in the coronary artery, and therefore coronary artery is not able to fulfill the oxygen demand by the myocardium. So this is very important, that when heart functions normally, that means the oxygen demand of the heart is getting fulfilled by the oxygen supply. And when this equilibrium is disturbed and oxygen supply is not sufficient, it leads to a condition called as a ischemia, and that ultimately leads to the angina pectoris. So it's an imbalance between the oxygen demand and the supply. Now, when we know that we have two domains to work upon, the one that is a demand of the oxygen by the heart, can we reduce the demand of the oxygen by the heart, or can we increase the oxygen supply by the coronary artery to the heart? So we have two grounds to play on. The first, that can we reduce the oxygen demand, and the second, that can we increase the oxygen supply, for which we need to understand what are the factors determining oxygen demand and what are the factors determining oxygen supply. Let's go one by one or step by step. Let's concentrate only on this half of our equilibrium part, that is oxygen demand. Oxygen demand is governed by the contractility of the heart. You all will agree with me that when a heart has to contract, it has to have an energy, and that energy can be gained by breakdown of the ATP. That means when a heart is contracting, there has to be a continuous supply of the ATP molecules which are generated through the oxidative metabolism. And if the oxidative metabolism has to generate ATP molecules, then it has to have a continuous oxygen supply. That means the contractility will lead, when there is an increase in the contraction, there will be always increase in the oxygen demand. And if that does not match, there is angina. So if we have to match it with a reduce or compromise oxygen supply, which is happening in angina due to the blockade in the coronary artery, we have to reduce the contractility of the heart. And if I have to reduce the contractility of the heart, I have to find out again how does the contraction of the myocardium take place. So when I learn about, I go in detail of the contraction of the myocardium to molecular and cellular levels, I will get the targets for my drugs. The second factor is the heart rate. When a rhythm of the heart is increasing, obviously the conduction system is governing. SA node is a pacemaker which will generate the impulse and will be filtered through the AV node, through the bundle of the His and Purkinje fiber. It will reach to the ventricular mass, and then the ventricular mass will undergo contraction. So when the heart rate increases, obviously the number of beats per minute are going to increase. The number of times the heart has to contract per minute is going to increase, and that will also lead to the increased oxygen demand. So when I'm looking for the decrease in contractility, I have to also look for the decrease in the heart rate. And the third very important factor is a wall tension. Because if the ventricular wall tension increases, as we already discussed, that when left ventricular pressure rises to 25 millimeter of a Hg, or when the volume of the blood in the ventricle increases, obviously it will lead to the increase in the pressure, also will lead to the stretching of the wall of the ventricle, will increase the wall tension, will increase the fiber length, and a oxygen demand is a function of the fiber length. Greater the fiber length, greater will be the oxygen demand, because with a more force the heart has to contract, because when a fiber length is increased, actin and myosin are pulled away from each other, and if they have to couple for the contraction, you need a greater amount of the energy, and if you need a greater amount of energy, you need a greater amount of oxygen. So if you reduce the wall tension, you are reducing the oxygen demand by the heart, and if you have to reduce wall tension, you have to reduce left ventricular pressure and the volume. So we have to work on these three important targets if we have to reduce the oxygen demand. Now when we come to the oxygen supply, we have a coronary artery with us, but the very important factor over here comes the arteriovenous oxygen difference, because that will determine the amount of the oxygen utilized by the tissue, that is our heart, myocardial tissue. The second factor which is important is that we cannot only target on the coronary artery, but its branches into the myocardium, because it is the deepest portion, that is a subendocardial, which is suffering from the ischemia. So it's very important that we have to restore back the regional blood flow also within the myocardium. And the third factor, obviously the coronary, once the coronary blood flow increases, obviously the coronary arteriolar blood flows and microcapillary blood flow will also increase, and therefore we have to focus on the factors controlling the coronary blood flow, and that is the coronary vascular resistance and the aortic pressure. Greater the aortic pressure, greater is going to be the coronary blood flow. But if there is a resistance to the flow of the blood in the coronary artery, then also that is one of the culprit which we need to resolve, which may be because of the atheroma, which may be due to the atherosclerotic plaque, or it can be due to the vasoconstriction, which also need to be attended. So we have to reduce vasoconstriction, we have to dissolve atherosclerotic plaque, we have to prevent the formation of the thrombus, so that the coronary blood flow can be restored back to the normal. The every factor we will discuss in detail. We will explore the various targets so that you understand before jumping into the chapter that why the particular drug is used for a particular type of angina. That will be covered in my second session. Thank you very much.